Hello, welcome to Myelopathy Matters, the official podcast of the charity Myelopathy.org.
Where we talk all things degenerative, cervical myelopathy from the perspective of the professionals, the researchers and the people living with myelopathy.
I'm Ben Davies, neurosurgeon scientist and a founder of Myelopathy.org.
I'm Iwan Sadler, a person with DCM and also a founder of Myelopathy.org.
This is Myelopathy Matters by Myelopathy.org. Welcome. So today we're looking at a role for CSF pressure monitoring in DCM with Consultant Neurologist and Scientist Dr Carl Zipser from Balgrist University Hospital, Switzerland, following his COMP-CORD study.
Isn't it great to be hearing from a neurologist? They're such an important part of the care pathway, but from what you've told me, Ben, underrepresented in the research fields.
That is certainly the case today, and really the first question I put to Carl: how did he become interested in DCM research? And how can we encourage more neurologists and related disciplines into our field? Welcome, Carl.
Thank you, Ben. Thank you for having me here.
It's a pleasure, and we're going to dig into your recent study, the COMP-CORD study, in just a second. But, I thought we'd start perhaps by getting a little bit of background of how you became interested in degenerative cervical myelopathy.
So I'm by education, I'm a neurologist, and I became involved in spinal cord diseases at the end of my residency, and then for my fellowship at the Spinal Cord Injury Center at Balgrist. And I did mostly rehabilitation of patients with paraplegia, but I was a lot involved with patients with DCM in the outpatients clinic. And then I recognized that there are many problems which need to be solved and the care needs to be improved. And so I got interested in doing research in this area.
And I guess my question was slightly loaded because I think, you're slightly unusual for the field in an academic space, certainly, because at the moment this is a field very much dominated by spinal surgeons, despite the fact that neurologists have an incredible role both in the diagnostic care and also long-term care for DCM. Why do you think perhaps we haven't seen more neurologists in this research space so far?
Well, I absolutely agree. I share this observation. And I think one issue is definitely that the awareness of DCM is still too low in the neurological community, which is partly due to the lack of diagnostic criteria, maybe. But I also got the impression that many neurologists perceive DCM still as a surgical condition because it's the only effective treatment up to date. But I also agree to what you were saying. In practice and research, neurological input is urgently needed.
How do you think we can encourage more neurologists to come into DCM and to tackle the issues that we're facing?
Generally, what I always try in my practice with students, but also at conferences, is to let's say to show and to present my fascination for the spinal cord. I think in some neurologists underestimate the fascination and the relevance of the spinal cord because recently there has been so much advance in brain conditions that the spinal cord went a bit into the background. But I think it's about time to get it back into the spotlight. And in DCM particularly, I think that diagnostic criteria are required, which is one of the goal of the Recode DCM initiative. So this one is really important because neurologists are very familiar with diagnostic criteria, and if there are no diagnostic criteria, it's hard to conduct neurological studies, I think. And then the carryover of all the knowledge from the spine surgeon and the neurosurgeon perspective into the neuro community must be done. And I think it's mostly with hard work, scientific articles, workshops, conferences, and presence in the medical curriculum as well.
So that perhaps turns our attention then onto your trial, the COMP-CORD study. How did that question come about for you?
So we had two issues we were concerned about from our perspective as spinal cord caretakers. One was that for the intraoperative monitoring of spinal cord patients, there were only methods available to detect harm to the spinal cord, so like evoked potential monitoring. but few methods to estimate sufficient decompression. So there's intraoperative ultrasound, for example, but apart from that, there is no mean yet. So this was one of our objective. The other one, which was more an overarching goal, was to investigate the utility of CSF pressure assessments in DCM, since MRI is not always correlating well with the clinical presentation. And we thought that the extent of spinal cord compression could be well estimated with CSF pressure analysis.
So in a normal situation, Carl, how does CSF flow around the cervical spinal cord?
So in a patient without any spinal cord compression or any brain condition which is affecting the CSF pressure, the compartment of CSF from the skull and the compartment in the spine, they are connected. So you obtain more or less the same pressure values. And what is happening that it's causing the CSF pulsations is that you have intracranial arteries, and those are oscillating, and due to the oscillation, it is believed that the pulsations are also transmitted to the CSF space, and they are synchronous to the arterial blood pressure. So when you see it, it's quite fascinating because you see a blood pressure signal, and always with a delay of around like 100 to 300 milliseconds, you see a CSF pulsation. And this is how it should be in a patient without a spinal cord compression. You should see at the intracranial CSF space, but also at the lumbar CSF space. As soon as you have a stenosis, the signals who are translated to, or who are transmitted to the lumbar level might be affected. And this was our hypothesis, that those signals might be dampened due to the stenosis.
I guess in a different sense then. So essentially what you're looking for is, there's a sort of constant set of waves coming up the stream, up in the head, and you're measuring downstream, and you're trying to see whether you can see the same strength of signal, which might be then, reduced or absent because of narrowing in the neck is the concept.
Yes, that's the concept, absolutely.
And let's just unpick that a little bit, because many people possibly listening will go, well, why can't the MRI just tell you how much of a decompression that you need to do? Why is that extra step, some sort of monitoring tool, going to be useful?
So intraoperatively, MRI is not well feasible yet. So there's still research on this going on, but up to date, it's not feasible in the routine. And also what the MRI is giving us is a very good structural, anatomical data set, but it's rather static. And at least what we believe yet, and what has been also confirmed with our initial data, is that CSF pressure monitoring gives an account of dynamic cord compression. What we consulted when we were designing the study were data from several years ago. So there was one study performed by Brian Kwon in Vancouver, in Canada, who did also CSF pressure monitoring in patients with acute spinal cord injury. And those were quite interesting studies, because he also saw that there was a response to the decompression during the monitoring. And we aim to translate the same concept to DCM, already bearing in mind that in DCM it might be very, very different from acute spinal cord injury patients. But the concept itself was established, I think.
How are you monitoring this pressure change?
Process from the method is that we insert a catheter at the lumbar level. So at this area, the spinal cord is already over. It's just like the remaining fibers going out of the spinal cord.
And what was the expectation about how that sort of pressure signal might relate to spinal cord pressure? Because obviously you're measuring a sort of fluid pressure as opposed to actually measuring the spinal cord pressure itself. So
we measured the CSF pressure. So the intraspinal pressure is also one method to go. For example, it's been done in London recently by Professor Papadopoulos, but also in patients with acute spinal cord injury. And the CSF pressure analysis is a different approach. So we are checking another compartment. So it's not the intraspinal space, it's the intrathecal space or the CSF space. And it's an indirect measure of the intraspinal pressure, because what we believe, what our hypothesis is that the higher the pressure on the spinal cord, the more severe the CSF pressure is affected below the level of injury.
And in terms of just looking at the sort of study design, perhaps we can come on to that a little bit to get an overview of how you approached investigating this question. One of the questions that I always think about is, trying to sell a lumbar puncture to somebody is quite difficult. It's not a procedure anyone wants to necessarily undergo. Is that something you encountered that's been difficult here?
No, fortunately not. So I'm always very grateful to all patients who are confident in us that we are doing a good job. And very few patients denied the enrollment for the catheter. And I think from a patient's perspective, two arguments were important. One was that the catheter is introduced when the anesthesia already took place. So the patients do not feel the insertion actually. And the other argument is that the catheter is inserted remote from the lesion level and remote of the surgical site. So we were not conflicting with the surgery in any kind, and this convinced most of our patients to participate.
What was the study design for the CompCord study?
So we conducted a prospective cohort study, and we enrolled patients with DCM who required surgical decompression. And in our study, DCM was defined as one symptom and one sign related to DCM and matching MRI. And in patients who had not clinical signs, the neurophysiology examinations could substitute for spinal cord damage. Other inclusion criteria were that patients should not have interfering conditions other than DCM, and patients should not have any contraindication for a lumbar catheter. For example, in patients with lumbar stenosis, we did not insert because that could also interfere with our measurements.
What did you expect to find in this study? Did you have an expectation of what you were going to see?
From the results we have seen a couple of years ago in patients with acute spinal cord injury, we were at least expecting what not to see. We were expecting to see quite subtle differences. So not too much a change of the baseline pressure, but we were expecting that the pulsations from CSF, so from the cerebrospinal fluid, that they are changed. And the way you can imagine it, just from the physiology, is that due to arterial pulsation in the brain, is bringing all of the brain into oscillation. Those are also translated to the CSF space, and the CSF is also then pulsating. And we thought of it as a system which is like interrupted and narrowed at the cervical level, and due to this, the pulsations should be dampened. This was our hypothesis, and we hypothesized that quite immediately during surgery, we should see the changes related to the decompressive maneuvers.
And so what were the findings?
We find in most patients a significant increase of the CSF pulsations related to specific surgical steps. And we were able to exclude that hemodynamic parameters, for example, blood pressure changes or the CSF baseline pressure itself accounts for these findings. And this is very important because I think when you are critical about the findings, and we are always very, let's say, discussing a lot of our findings, one issue to me was always, is it a refilling effect? So is it that after we insert the lumbar catheter and we lose some CSF during the insertion, is it just the refilling which makes the pulsations increase during surgery? But our analysis have shown that the increase is really related to the surgical maneuvers and not happening before. And also that the baseline CSF pressure is changing not significantly. It's a very, very low number, whereas the pulsations increase a lot.
Mm-hmm. And can you break that down? And what were the steps that seemed to trigger that change surgically?
What we did were that most of the surgeries were video recorded. And what we did then was to consult one of our surgeon to look through the videos with me and to see whether there are any, what are the specific steps related to the beginning of CSF pressure changes. And we found that in most patients, it was not, let's say, the access to the surgery site or the end of the surgery which was making the difference, but it was the decompression. So, for example, the removal of discs or a corpectomy, so the removal of a vertebrae, or the removal of the ligaments. So it was always the decompressive action which changes the signal.
And that change was fairly immediate, was it, with the release of those, or the removal of those structures?
Yeah, it was interesting, and this was not as expected. We found like different types of changes. So in some patients we found quite immediate changes. So really like from 1 second to the other, and in others it took a while. So it took like 5 to 10 minutes. But it's also related to the surgery, that it's not always, the decompression is not always one single step, but it's like different steps leading to decompression in the end. So in many patients it was a gradual increase, but still when the changes were always present as soon as the decompression took place.
Fascinating. And did everyone achieve then that change in or that return of the pulsatile flow?
At baseline, we had pulsations present in most of the patients. So it was not that they were like totally absent. And one issue is that we do not only see different evolutions, so not only gradual and immediate increase, but we also see different morphologies of the pressure waves from before to after decompression. And some patients started with very low pulsations, and then after decompression they had very high ones. Whereas in others we had quite well preserved pulsations, and then there were only little changes in the end. So we achieved some changes in every patient, but the extent was very different and was highly varying. In some we had huge changes, in others more subtle changes.
And have you tried to reconcile that? Why do you think that is?
So this is one of our most important questions for further data analysis. What we saw so far is that the extent of change is of the pulsation is between like 10-20%, but in other patients it's nearly doubling, and in others it's like a black and white difference. It's like going from nothing to a huge pulsation. And I think it's really related to the individual patient characteristics. And this is one thing which was particularly challenging, but also something very interesting and very important to my mind, that we tried to kind of mix a cohort analysis, but also going into the single subject analysis as well. Because patients with DCM, they are so different. They are so different properties, going from the different length of symptoms and going to the MRI properties. So is it more like the bone which is compressing, or more the ligament? And what is the age of the patient? So there are many factors which might confound the findings. And to date, we cannot surely tell which ones are the decisive ones, because the cohort is too small to do subgroup analyses yet. So we need some more patients to do like real subgroup analyses and tell which patients has which pressure profile.
And so I guess then that sort of leads on to really where are you going next with this investigation?
One important issue for us is to complete the follow-up. So we had yet a 6-month follow-up available, and we were really happy that we saw that most patients actually had a clinical improvement. This was great to see. And one thing is that we want to investigate the 12-month follow-up and also the correlation with the MRI, because we expect that there must be a certain correlation, or it could be that there is a certain correlation to the MRI findings as well. And we do a baseline and also a follow-up MRI. And this is one goal we want to achieve. And the other analysis we want to continue is the analysis of the spinal cord perfusion from the data we acquired.
And so clearly some important steps still to come, and it's just clearly sounds like there's more ground to cover before we can see this as a sort of routine part of practice for sure. But sitting where you are now, having done this study so far, what do you think are the implications or applications of this technique for DCM?
What I definitely think from what we see now is that in patients who have like complex spine, who undergoes complex spine surgery, so patients with multiple levels of stenosis, patients in which the surgeons can already anticipate that they have bad side on the surgical ground, I think it's a method which could be very, very useful. It's not a method for everyone. So I think we are in steady contact with our surgical department. They are very good collaborators. It's with our director, Professor Farshad, and in the discussions we have with our surgical team, we always emphasize and come to the common conclusion that it's not a method for everybody. In some patients, it's not necessary, but in some patients, it's a really desirable instrument to estimate that compression is fully done.
Mm-hmm. No, that would resonate with me. I think you get that some sort of live readout is very powerful, because there is a shift to using ultrasound for that purpose. But particularly with anterior procedures, the probes are quite difficult. It's difficult anyway, but also you're only really getting a visualization of the piece of the theca, the spinal cord that you've exposed. So you could miss areas off your view, if you like, which obviously with a CSF pressure monitoring presumably would be picked up. And one of the things that occurred to me as well, and you mentioned that future analysis on perfusion, is this something that could help the anaesthetic team intraoperatively? Obviously, spinal cord perfusion it's obviously important, and it's going to be modified a lot by the anaesthetic treatment that patients go under during the operation.
Yeah, I definitely hope that we can contribute to this important question of hemodynamic management, because already in the field of acute spinal cord injury, there are lots of questions, and in DCM there is basically no evidence at all how to best achieve the spinal cord perfusion during surgery and also after surgery. And what is already established is a way to calculate the spinal cord perfusion pressure from the CSF pressure and the mean arterial pressure. And we also have this data because in addition to the CSF pressure, we also record the arterial blood pressure. But still, it's a rough estimate, because it's the CSF pressure is some, let's say, global parameter, and how much the spinal cord perfusion pressure we calculate is giving us an idea about the site of injury. It still needs to be investigated, but we have this data and we want to explore it to see whether there is any use. It would be very, very important and a very important step.
One of the other areas I was interested to see whether it could, sort of explore as well is, in the sort of diagnostic workup. For example, asymptomatic spinal cord compression. Do you think there's an application here for CSF pressure monitoring?
Yeah, definitely. The intraoperative monitoring is only one part of this whole endeavor to investigate CSF pressure. One other is to to see the significance of CSF pressure assessments at bedside. So patients undergoing lumbar puncture and then assessing the pressure and the pulsations. And what we did so far in this was to test a healthy cohort. So, or let's say a cohort of patients without mechanical spinal cord compression. And for this cohort, we are currently trying to set up kind of a set of reference values, because interestingly, in the CSF physiology community, we have normal values for CSF opening pressure, but for pulsations, for example, there's very little evidence how they should be. So what is a normal pulsation pressure is not clear yet. And this we want to further investigate. And what we do yet already in our clinical practice is that in patients, as you mentioned, with asymptomatic spinal cord compression, or also in those patients who have a discrepancy between the clinical findings and the extent of stenosis, we are doing bedside measurements already. So we estimate pulsations the best we can, and we use Queckenstedt's maneuver as well. Queckenstedt's maneuver, it's a traditional test. Has been invented in 1916. I can tell you more about that.
Yeah, please do. I was very interested to read about that study, that test. I've never heard about it.
The first time I heard about it was from my supervisor, who's also the director of the spinal cord injury. It's Professor Armin Kurt. And when we designed the study, he came up with this test from his experience in spinal cord injury. And it's a test which has been named after a German neurologist. So a doctor named Hans Queckenstedt. And he published a paper in 1916 where he described from a small case series this test to diagnose spinal cord compression. And it was used frequently before spinal cord imaging was allowed us to visualize spinal cord compression. And it's performed by firm pressure on both jugular veins during lumbar puncture. And a positive response is usually defined as a pressure increase in CSF pressure from baseline, and usually it's between 10 and 20 millimeter mercury. And in patients who have severe spinal cord compression, we see that this response is usually reduced. And one important thing, and what was really interesting to me, is that you cannot only do it in a patient in resting position, but you can also move the head and make the same maneuvers with head inclination or head reclination. And this is a very interesting task because you might be able to better estimate the dynamic cord compression. And this was what fascinated me so much about it.
So that's really interesting. So just to unpick that a little bit. So essentially those maneuvers at the bedside are designed to elevate the CSF pressure in normal circumstances, but in patients with stenosis in the neck, they would be dampened.
Yes, so you cannot, what you do by the vein compression is that you increase the intracranial pressure, and what usually happens is that as soon as the intracranial pressure is increased, this pressure increase is also transmitted to the lumbar level. And as soon as you have the cord compression at the cervical level, the Q test is not longer responsive at the lumbar level.
Fascinating. And so presumably that study is ongoing, and how is that playing out? Because I guess the benefit now is you've got very detailed readouts of these pressure waveforms, which obviously historically was probably measured with a simple pressure one-off reading. Yeah,
definitely. So in the past, I think there are different things that we change compared to the past. So Queckenstedt's test was abandoned for a while. So as soon as imaging was feasible and was sensitive to detect cord compression, at least like in a structural way, it was abandoned. And now we do not want to challenge imaging with Queckenstedt's test, but what we want to investigate is whether CSF pressure assessments and including Queckenstedt's test may give us an additional information, and that is a totally different question than our ancestors in spinal cord neurology had 100 years ago. So at that time, they had no other chance to estimate compression than by this. And today, what we are doing is very different to the past, because we have, as you already said, we have advanced our technical possibilities by digital recordings. So pulsation analysis was not feasible with analog manometer. So this is something really different. And also the way we see at Queckenstedt today is that we do not only want to measure the absolute increase of from baseline of the Q test, but we also want to analyze the subtle changes during Q test. For example, the increase of pulsations on the top of the Q test which occur, and this has never been looked into. And we expect that this might be like an additional readout.
Mm-hmm. No, it's fascinating. It's a sort of a reminder to me, I think, of perhaps how with MRI over the last 30 years, whilst it gave us some tremendous gains, I think it's potentially sent the field down a bit of an alleyway which we need to retreat back from. We started to see things visually on the MRI of compression. We thought this disease was all about compression. We treat compression, etc., etc. But as time's gone on, we recognise that is not a perfect framework for this disease, and we need to step back from that and I guess reapproach concepts which predate MRI. Things that have been dormant for 30 years.
Yeah, absolutely. And what I would add to this is that in particular for the follow-up, it's for follow-ups in surgical studies, but as well in other interventional studies. So let's say studies which test innovative drugs in DCM or cell therapies. It's not so easy to use MRI as a readout, and also clinical readouts are not always so reliable, in particular with the scores we have yet. And all of these need to be advanced, and I think CSF pressure analyses might be one additional parameter which can be introduced, in particular when you apply intraspinal drugs or intraspinal cell therapies, because you may check whether the decompression in patients is sufficient.
What a fantastic interview, and it's great to see other methods being used as MRI imaging isn't 100%. What do you take away from this study, Ben?
In short, I think what an incredible and underexplored opportunity. There is clearly more work to be done to prove the value of spinal cord pressure monitoring, but the concept, feels right to me. CSF pressure monitoring has a much more developed history in other conditions such as traumatic brain injury and traumatic spinal cord injury, as well as a condition called hydrocephalus. So the importance of treating pressure changes to prevent tissue injury is not something that's totally alien or without scientific precedent. But more than that, I think that this could be very timely for DCM. It's cropped up during the interview, but we have a problem now that we haven't got a perfect test for DCM. We rely on MRI to help diagnose DCM, to help decide the surgical treatment. But if visualized compression is not a specific marker for DCM, it means that surgically targeting that compression may also not be the specific endpoint of the operation itself. So having a tool to tell you in real time would just be amazing, at a point in time you can actually do something about it. There is this increase in using ultrasound during the operation. I haven't got that much experience of doing that myself, but my feel is that probably they're quite bulky probes, quite difficult to use, and you can only really see the area of the spinal cord that you've exposed. You would miss things that perhaps you hadn't reached off that viewpoint. So I think long and short, it feels like a great opportunity, this, and something that's really got great potential. I guess the downside is the lumbar puncture that's required. Do you think the community of people affected would be happy to have that done, Ewan?
I've actually had 2 lumbar punctures on my myelopathy journey. I ended up in A&E with neck pain and a really bad headache, so they tested me for meningitis due to the symptoms. I think the word lumbar puncture is a lot more frightening than the actual procedure itself. from my point of view, it really isn't that bad. So I don't see it as a problem, not after my experience, especially if the person has had sort of spine surgery in the past. The lumbar punch, in comparison, is a walk in the park.
Well, that's reassuring to hear. And I think it was obviously good that the study itself found it was a safe procedure, didn't add any untoward problems. Well, that is the end of this episode, but also the end of this series. We'll be back in 2022 to keep you up to date with the latest developments in degenerative cervical myelopathy. If you'd like to be part of Series 3, please do get in touch. Email me at ben@myelopathy.org. A reminder, of course, to subscribe on your favourite podcast platform. Our thanks to Carl Zipser for joining us, to Carl Homer from Cambridge TV, our producer, and finally the National Institute for Health Research, United Kingdom, an award from whom supported this podcast series. But of course, the views expressed are not necessarily those of the NIHR, National Health Service, or Department of Health, United Kingdom. See you in 2022.